We have the next talk on when should an oncology opinion be sought in gynecology. This is by Dr. Neethu Sukesh. May I please welcome Dr. Neethu Sukesh on board. She is the assistant professor, AIMS Kochi. Welcome, ma'am, and over to you.
A very good morning to all of you. Thank you, Dr. J. Krishnan, for this invite. After all the sweet things, I'm going to put a little chili on it. Hope you enjoy my humble endeavor. So, when should a gynae onco opinion be sought? It is a bragging like request for some patients. Yeah, you can say that. So, let me start with, I'm so sorry for this. Can you see? Let me start with some cases. These are not like I had to look back into my all my experience and bring them. These are like last 2-3 months at the most. This is about a 62-year-old postmenopausal woman who underwent a total abdominal hysterectomy and a BSO in 2017 with a normal histopathology. In January 23, she experienced bleeding per vaginum and a perspeculum was done and a wall biopsy. The smear came as malignant cell favoring adenocarcinoma. Query endocervical biopsy, papillary adenocarcinoma, query endocervical. Staging laparoscopy converted to laparotomy and excision of the vault, bilateral lymph node dissection and an omental biopsy. What does it come as? Adenocarcinoma, size is 4.5 into 3.5, margin, depth of invasion 11.8, LVSI present. See, if you have any context of cervical cancer, you would know that this is glaring at you, this at least criteria, you have to give adjuvant treatment. No adjuvant treatment was given whatsoever, and she recurred in May 2024. So, anybody can do the surgery. It's about gynae oncology to know the whole perspective of it, how to proceed, when to give, when not to give. That's the whole perspective of gynae oncology. This is about another 50-year-old P2L2. She had an ultrasound which showed that multiple fibroids and a cervix which was large, thick, which shows widening, lesion. Nobody bothered. She just underwent a THBSO. I wonder if anybody did a perspeculum for her. And histopathology came as squamous cell carcinoma. And she presented with a non-healing fan and steel incision. I had to dress daily. And the horror and the pain she went through for a malignancy which could have been just treated with a chemoradiation. So her whole PET CT showed deposits in the rectus abdominis, which would have been a stage 3, was made stage 4. Most of these things happen and nobody complains, so it just keeps happening. So she did not respond to the chemotherapy. Obviously, cervical cancer, when it goes to chemo, stage 4, it's very difficult. This is about a 58-year-old patient, initially evaluated for an incidentally detected pelvic mass, which was for a suspected hernia. So what glared at the physician was a primary malignant ovarian neoplasm. And she underwent a staging laparotomy and everything. You know what came up as a slide and block? It was a non-keratinizing squamous cell carcinoma of cervix. Even if an ovarian tumor is glaring at you on the screen, please look at the cervix, please look at the uterus. There could be some other. This was almost a 10-15 centimeter metastasis into the ovary, but somebody missed the cervix. She could have been treated better. This is no different than the previous case now. This is another 31-year-old woman. She just came last month, who was presented with irregular menstrual cycles, low back pain, bilateral lower limb pain, and burning during urination. Nothing to suggest anything otherwise. She was outside treated, underwent laparoscopic fulguration of endometriotic lesions, Mirena insertion, and received an injection of leuprolide. However, symptoms persisted and she landed up with her a perspeculum. I could see there was an infiltrating growth of the cervix. And MRI supported also cervical malignancy. I wonder how somebody put an Mirena when not thinking about even a pap smear. Okay, you could miss the infiltrating growth, okay. But why not a pap smear? 31-year-old. We have patients at 27 to 30 with vulval malignancies and cervical malignancies. I can't stress enough for the vaccination. But yeah, we have to change. She has stage 2B. I couldn't even do surgery for her because the parametrum was involved. She went for chemoradiation at 31 years. This is about ovarian cancer. A 30-year-old, again, nulli gravida, a large multiloculated cystic lesion up to the epigastrium. I don't know why we have to show heroics when we have a tumor up to the epigastrium. It is no heroics. Anybody can put in a syringe and aspirate a balloon. That is now heroics. What do you do to that patient? It is mostly mucinous. And mucinous, even if it is benign, if you spill the mucin, the patient can anytime go for a pseudomyxoma peritoni. You should learn, we should learn to normalize scars. Scars are beautiful as long as you live a full life. This patient had a laparoscopic adnexectomy and the histopathology came as borderline mucinous tumor. Possibility of carcinoma could not be excluded due to the fragmented specimen. We lack there also. Large tumors like this, even if you do a frozen, what happens is that there is a difficulty in evaluating whole of the tumor. And mucinous can have a small area of malignancy, but they recur just like a malignancy. So this is one request. When you have to have a scar, that is okay. I have a patient who had a lesion up to the epigastrium. She was hardly 35 kilos and the lesion was up to the epigastrium. She had a kid. We did this staging with open. The cyst was unruptured. It was a mucinous carcinoma. She had another pregnancy in a year, delivered normally, and she comes to follow up for me. And she says the second kid is only because, doctor, you told you have to get pregnant. So that is also possible. But there are other patients who had a laparoscopic dissemination and had recurrences within a year. This is about a 24-year-old who had an irregular menses since menarche, regular story, but there was a left ovarian cyst which was removed against cystectomy. When you see a solid tumor, juvenile granulosa is always solid. Please wait. And juvenile granulosa is aggressive than an adult granulosa tumor, and she had a recurrence as well. This is about a 30-year-old lady who had a secondary infertility. Initial finding was an adnexal cyst, suspected to be a chocolate cyst. But there were septations and solid areas, mind you. She had all laparoscopic cystectomy and the note said fluid content was sucked out. And the impression came as an endometrioid adenocarcinoma at 30-year-old. If it was removed without pillage, I could do a fertility sparing surgery. I could just remove one ovary lumentum, do a peritoneal staging, lymph nodes, and come out. She could still get pregnant. But now, because it's an endometrioid carcinoma, it's spilled, she has to undergo a full staging, remove everything, including the other ovary. So that's the option that we deprive the patient of. So where do gyne-onco come in useful? Patients with a confirmed diagnosis of any gynecological malignancies. Gynecological malignancies diagnosed after inadvertent hysterectomy, adnexectomy, cystectomy. Suspicious cases not responding to conventional therapy, follow-ups, intra-op assistance or referral of complex pelvic surgeries like endometriosis, all patients with borderline ovarian tumors, assistance for placenta accreta spectrum, opinion in mapping disease for MRI CT in endometriosis. So this is a study, importance of the gynecological oncological management in placenta accreta spectrum, and they say that gyne-onco are more likely to have complex cases. They have improved patient outcomes. And surgery by a consultant gyne-onco improves survival in patients with ovarian carcinoma. I think that goes without saying, even better than a surgical oncologist. Gyne-onco, because tumor removal more often complete and survival was improved. And I also think it's more of like a perspective. When a gynecologist becomes a gyne-onco surgeon, we have the perspective of a gynecologist and the eye of a surgeon as well. So that is different. So what are the potential strategies to increase gyne-onco treatment for ovarian cancer? So this is what I am doing now. We could increase knowledge awareness of the role and importance. We could improve the models of care, payment structure improvement, increasing insurance coverage, enhancing our workforce. At what point should gynae-onco be involved? What should you consider? When should you consider the possibility of ovarian malignancy? So, ORADs, we have a lot of options: ORADs, IOTA, RMI. So, I know you all have heard about it. ORADs goes from 0 to 5, color scores, and all those things. ORADs 1, I'll not be bothered. 2, almost certainly benign, mostly. But when it comes to 3, I would really be bothered. When you see a cyst more than 10 centimeter, when you see a unilocular cyst with irregular inner wall, when you see a multilocular cyst with a color score, or any solid area, please don't jump to do a cystectomy. At least that much we can do. If you don't want to do an ovariotomy or an adnexectomy, at least wait. The malignancy shows itself in a month or 2. It will change, and it will show you that it is not what you thought it was. Rather than compromising on her fertility and her survival, just wait and watch, but don't let her go. So 4 and 5, I'm sure anybody would know they are multilocular and color flow and irregular solid and all those things. Anybody would know that that could not be meddled with. So another one is a RIATA group. Everybody knows the M rules and B rules. I'm not bothered at the M rule. We have a irregular solid tumor ascites. Everybody knows what to do. What is the problem is the unclassified, where you don't know what to do. So, but I would really suggest, if you see a solid area, there is an increased blood flow, you see a papillary structure, you see multiseptate tumor with a thick septa, please watch. I wouldn't ask you to refer even. Please hold on to that patient for a month and see. You do the tumor markers. Well, tumor markers can be very normal. Day before, I did a lady for 43-year-old. Her CA125 was 13. All tumor markers normal. There was an acute, she's telling 3 months. But I asked her left and right, is there a history of endometriosis? Is there a fibroid? It was so tense. It was a cystic tumor with a solid area, obvious solid area. So, you know what it was when I opened, it was a long-standing endometriosis and acute serous, high-grade serous, that too. The tumor was everywhere, it was so infiltrating. So with the normal CA125 also, we can't be very sure. So hold on to that patient, the tumor will show its colors, it will become solid, it will become suddenly grow or whatever, then you can act accordingly. If not, well, go ahead with what your plan was initially. So the color score, any color, I would be bothered. So serum markers in gynae-onco, we have a lot of serum markers. In any lady more than 40, I wouldn't be bothered to do anything more than a CA125 and a CEA. I don't know if people believe in HE4 and CA19.9. Sometimes we don't even know what to do with an elevated CA19.9. We keep asking GA surgery, do you want to do anything? They are like, we don't have to do anything. So CA125 definitely. CEA is elevated in mucinous cancers, and another thing is GI cancers, sometimes breast, thyroid, everywhere. So if you see a raised CEA and the ratio is more than 25:1 for CA125 and CEA, you look into your breast, thyroid, everywhere, even an endocervical or an endometrial cancer. So everybody knows it's elevated in multiple benign conditions, 80% of the cancers, but only in 50% of the stage 1 disease. So the predictive value is consistently higher in postmenopausal women for CA125. This threshold, like you'd say 200, more than 200 and you have to refer, is just based on expert opinion. It's no guideline. So just use your own this thing. Whenever a patient comes with a history of cyst, you always ask for history of endometriosis, right? Usually, mostly, they have a history of dysmenorrhea, long-standing, and all those things. If not, I'll come to endometriosis later. If it's a newly developed lesion and you have this raised CA125, you have to be careful. And in less than 40, LDH alpha fetoprotein, there are no serum biomarker that is both highly sensitive and specific for the diagnosis of endometrial ovarian cancer. Panels, not recommended, not yet defined the best testing approach. We don't do it. And you have the RMI score. If you want to calculate the RMI score and more than 200, you can refer to a gynae onco. That's also welcome. So individualize and go ahead. Premenopausal, less than 8 centimeters, cystic, observation with or without suppression for 2 months. And if there is no progression, go for surgery. But if it's more than 8 centimeters, complex, solid, suspicious, then go for surgery, but be plant and have a gynae onco on call. Postmenopausal, always prefer surgery. So I want to shed light on an endometriosis associated ovarian cancer. Just because it's endometriosis doesn't mean it will not progress to cancer. 0.5 to 1% affected by ovarian neoplasia and can occur in up to 2.9% of endometriomas. So the most common are clear cell, endometrioid and low grade, which don't respond to chemotherapy, and surgery is the best option, and you have to contain it and take it out without spreading it much. So we have histological findings of atypical endometriosis, and it is present in 12 to 35% of ovarian endometriosis. Approximately 60 to 80% of endometriosis associated ovarian cancer occurs in atypical endometriosis. Also, endometrial cancer is more common in endometriosis. They can be synchronous ovarian endometrioid cancer. How do you know? They are typically vascularized solid component. A 45-year or older with an endometrioma of size 8 or more are significant factors that independently predict the development of ovarian cancer in women with endometriomas. Malignancy indicators like increasing tumor size, rapid growth, papillary excrescence, thick septations are crucial. Role of frozen section. You decide, okay, I'll just go for a frozen section. I'm not going to wait for this. Let me do a frozen section. In intraoperative histological assessment, help clinicians to prevent under or over treatment. Yes, benign lesions are managed conservatively, but malignant can be treated accordingly. It caution in large ovarian and mucinous, as I told, you can't sample every other area in a large ovarian tumor. Usually in frozen, they cut open and see if there is a solid area, they just sample that area. There might be a small area which is missed. So you might miss the chance of treating a malignancy in one go. But when you send frozen, it implies you take action on it. If you are sending frozen, your incision should be midline vertical because you want to extend it to a full midline incision to go for staging. You should have a gynae onco on call. You should have a consent to go ahead with a full surgery, including bowel resections if necessary. You should have warned the anesthesia that this is going to be a longer surgery if it turns out positive. When should you consider the possibility of endometrial cancer? Okay, we have the IETA terminology. I'm not going into the details. You can go along with it. There are n number of papers on how you can use IETA, how it is showing a polyp, leiomyoma, endometrial cancers. So, what I would like to say is that although the different histological, can I complete it, please? Okay. You have to be aware of the outliners as well. Thin endometrium with malignancy is also a possibility. Even less than 3 mm, you can get a bad kind of serous cancer. So always do a gynecological examination. Per speculum can show you a polyp infection. Always look for the cervix. There are n number of cases where you do a pap smear, but the result is negative for a CS cervix. Pap smear negative. How can it be? You never took it from the cervix. That is it. Don't miss the vulva and vagina. Don't just go in with the speculum and look at the cervix. Look, take time and look at the vulva, vagina. Do an endometrial sampling in a case of heavy menstrual bleeding. Always imaging, pap smear and endometrial sampling in postmenopausal bleeding. If there is a growth in the uterus and the sampling is negative, don't morcellate. Sarcomas are not evident in sampling. So when do you consider sarcoma? There are morphological features which can tell you that there is a sarcoma. Of course, metastatic spread. There is a mnemonic like better in MRI features with the border enhancement S1, T2, T1, endometrial thickening and restriction diffusion patterns. And there are differentiating features from sarcomas and fibroids. What was the reason for improper simple hysterectomy in cervical cancer in Northeast Asia? The failure to perform a cervical cytology was the highest one. Normal cytology despite invasive cervical cancer, I'm sure nobody took it from the cervix. and lack of preoperative cytology, incomplete evaluation, failure to perform the indicated conization and an emergency, errors in colposcopy, incomplete evaluation, failure to review the slides, failure to biopsy a gross cervical lesion, 3.8%. These all ended it with an inadvertent hysterectomy, as I told, and we ended up with harming the patient. So the combination of cytology, colposcopy, endocervical sampling, punch biopsies, and indicated conization. Vulval and vaginal cancers, keep it in mind, look for it. Take that biopsy if you have a doubt, even a little bit. Refer if in doubt. Thank you.
Thank you, Dr. Neethu, for that timely and thought provoking session clarifying when to bring oncology into the gynecologic conversation was truly invaluable.